Okay, thank you everyone for being here. Before I start in, I just want to let you know that our third breakout speaker, Catherine Gilliam, is not here. She had a family emergency, illness and COVID and elderly grandparents or elderly in-laws. So for our third breakout session, we'll take a break after I finish, and then we have the microscope, and we can do some slides because I'm going to be talking about the microscope and the microbiome today. So we can dive deeper into that. We can answer questions with Karen. Fran, I'm sure, will be back, and we can talk more about our talk from yesterday. Or you can go upstairs and or to another breakout session. So just so you know, I apologize for Catherine. She is so sad to not be here, and she wishes she could. So she's here in spirit. And but we'll kind of punt for that third breakout session. So that said, welcome to Rebel for a Root Cause, Bugs, Biofilm, and Beyond. My disclosure is, as Debbie just told you, I work 2 days a week as a clinical dental hygienist in the office of Green City Dental, which is an airway-focused biological office. And it changed my world. And I will never, ever go back to being a traditional buff-and-go hygienist. And I'm also, because of all of this rabbit hole I've gone into, I'm a myofunctional therapist. I own my own business. And again, I can't imagine not working with airway. It is the missing link. It's the other half of dentistry. So I encourage you, if you aren't myofunctionally trained, to go get that, because that will open your eyes to all of the other dental problems and solve a lot. And then I am a member of the IAOMT. I'm chair of the Biological Hygiene Committee, and I'm on the board. And then I invite you to my blog, queenofdentalhygiene.net, and my email address is on my blog. And if you have questions, I am always here to help you in any way to help you grow as a biological hygienist on your journey, or a dentist. I'm more than willing to help you. So today we're going to talk about, why I'm a biological hygienist. And then my mantra is test, teach, treat, repeat. That's what I'm doing as I'm working with my patients. So this is the only picture I have of me from dental hygiene school. I didn't have a cell phone then, and I didn't have a camera. I graduated 40 years ago. And I went into healthcare to be a healer. That was my goal. And instead, my first year of dental hygiene was the worst year of my life. And I was the cleaning lady. I was always 30 minutes behind. And the day I had 3 patients all at once, because I was 45 minutes or an hour and a half behind, and then my next patient was there, and then my next patient was there. I was like, oh my gosh, I have to do something different, because I cannot live like this for the next 20 years. I cannot do dental hygiene like this. It was so depressing. I was miserable. I was, exercising. I was doing all the things, but I was seeing 10 patients a day, 50 patients a week, and it was like, I can't do this. I am not the healer I want to be. So I went on, instead I looked like this. And you can't heal somebody by just scraping and polishing, and then throwing a toothbrush at them and saying, hey, I'll see you in 6 months. And you know that they're full of disease and nothing's going to change. And even as a baby hygienist, I was there for 6 months, and it was like, well, I just saw you 6 months ago. And this is the same stuff I took off 6 months ago, and it is back. So one of us is doing something wrong, and it's probably me. And so I left dental hygiene after 1 year. And I moved 2,000 miles from Florida to Maine, went to grad school. I have a master's in business because I wanted something as far away from dentistry as possible, because if I was working in a high-end implant office with the renowned doctor in west coast of Florida, and I was miserable. My care was miserable. I was like, I can't do this. So I was doing dental sales, working on my off days. I went to school full-time at night, and then I worked during the day. And I walked into a dental office that changed my world. And this is the man that changed my world. I want to introduce you to Dr. Paul Keyes. And Dr. Keyes was a researcher, I think, with the National Health Institute. And he talked about caries before caries were a thing. And then he started modulated, monitored periodontal therapy. And he took plaque samples, put it on the microscope, and showed the world, or showed the dental community, what was underneath there. And this man was blacklisted and shunned and was told he was a quack and a wackadoodle. And being biological, you've all been called wackadoodle and woo-hoo and all of that. But he was kind of the first wackadoodle. But what he was saying resonated with me. And I got to meet him, and it changed my world. And so I will no longer practice without a microscope. I have been using one since 1985, and I won't practice without one. It is my right hand and my left hand, because I want to know what's underneath that tissue. I want to know, is that patient really infected? Do they have yeast infections? Or is it systemic? So the microscope really is, and the patients get it too. They understand when they see that microscope teeming with bacteria. They want to know what they can do right here, right now, and I want you to see my husband, and I want you to see my kids. And so even during COVID, when everything was shut down, I was busy as I could be. And so the microscope pays for itself, it educates the patient, and they want to know this information. And I want for every dental hygienist, my dream is for every hygienist to have a microscope in their operatory. Can you imagine the level of oral health in the United States if every hygienist had a microscope and could show their patients? Wow, it would change how we do dental hygiene. So Dr. Keyes said a dental hygienist without a microscope is like a doctor without a stethoscope. You have to see it. This slide is teeming with spirochetes, and we're going to talk more about spirochetes in just a little bit. But this is what we're dealing with every time we put our scaler into that pocket. Because when you put your scaler into this pocket that's a bloody mess, you're introducing these spirochetes into the bloodstream, and you're causing a bacteremia. Every time this patient chews, they're causing a bacteremia. Every time they brush, they're infecting their body. And we have a really important job as healthcare providers and healthcare prevention specialists to know what we're dealing with. So for me, being a biological hygienist, and I actually prefer biological dental healthcare practitioner, because as a hygienist, that keeps me the cleaning lady. So my other goal is for us to change the name of our profession, or at least our biological group, so that we are true healers and healthcare professionals. I want to look for the root causes of dental diseases. I want to treat conservatively, and I want to treat safely in the least toxic way possible. And I can't do that if there's mercury, if there's chemicals in the office. I want to be minimally invasive. I want to help the body to heal itself rather than just scraping and polishing. I want to practice true prevention, because we are the prevention specialists. And if we aren't testing, then we don't know what we need to do to be prevention specialists. And then I want to put the mouth back onto the patient's body, because for so long it's been sitting over here, and we've been working on it independently from the rest of the body. And as you know, because we're called woo-woo, You know, we have to be science-based. We have to have the research. We have to deal with it from that aspect. So as my good friend, Fran Horning, talked about yesterday, Paracelsus, the 4 pillars of health, and that actually helps guide me. You know, I was doing this before I knew about Paracelsus. You know, so when we do hygiene, we need to detoxify, we need to eliminate, we need to restore that microbiome to a healthy place, and that is with nutrition. So we have to incorporate the whole body in our patient's healing. And then rebalancing the regulatory system and the cell regeneration. We can't just scrape our way out of this. And then resetting the autonomic nervous system. So I implore you to look beyond the teeth and gums to help heal your patients. Because what happens in the mouth doesn't stay in the mouth. You know, this is a thermography from a good friend of mine, and you can see the drainage from the mouth to the breast. These are pathogens that are going into the body. So it's quite dramatic to see that what we do has wide-ranging effects. And 50% of heart attacks can be triggered by our bacteremias. And that can be triggered up to 4 weeks after we have put our scalar in that pocket. It takes 1 minute. Oh, where's my, there we go. Takes 1 minute for these spirochetes to get everywhere in the body. It's like a roulette ball, and where it ends up and stays makes it real. I mean, look at how they're attacking that dead white blood cell, and they're having lunch. And the more organized they are, the more dramatic that is, the thicker they are, the older they are, the more virulent they are. And I showed this slide yesterday in our biological 4-hour course, but I want to bring it up again because not all of you were here yesterday. This is a research study from 2016 in the Journal of Neuroinfectious Diseases, and the yellow highlighted part says the organisms enter the brain during a bacteremic phase of a dental procedure. And this is Alzheimer's disease. Our bacteria are going into the brain. So that roulette ball that's zipping around could enter the brain. And we are introducing it. So this is, for me, it was a game changer. It's like, I really need to step up my game so that I am not causing bacteremias. 93.7% of Alzheimer's disease patients have spirochetes in their brains. And where are the spirochetes coming from? Right here. So bacteria in the brain are not the result of Alzheimer's, but they could be the cause. I can't say causal yet, but we do know that the latent stages of Lyme's disease and syphilis are dementia. So how can our oral spirochetes not do the same? There are 57 different varieties of spirochetes. We can't culture all of them. So there's still a lot that get by our salivary diagnostic testing. But I see spirochetes on my microscope slide. I just don't know what they are specifically. And I hope you can see how thick that is. And then up in the upper corner up here, there's a brush pattern. We've got white blood cells, and then just the thick of the spirochetes. And more research from the Journal of Alzheimer's Disease that Porphyromonas gingivalis is a risk factor, and he is the keystone pathogen. And then Alzheimer's disease, spirochetes, a causal relationship. So the research is coming, it's out there, but I can't say causal yet. But gosh, I just, you know, when you think about the biofilm that we get in the mouth, How can they not do the exact same thing in the brain? And biofilms are impenetrable. We can't get antibiotics through there. How can they not be in the brain at the same time? And then the Journal of Neuroimaging talks about sleep apnea. And so this is where I put my myofunctional hat on. And that's why this is so important for all of you to also be airway trained. Because sleep apnea makes the blood-brain barrier permeable, according to this research. So now, instead of this steel trap door, we now have a screen door. And our spirochetes can burrow right in. They just wiggle. They love getting in the lymph system, the nerves, the bloodstream, and they stay alive and they travel throughout the body. So, you know, being aware of before you put your instrument in is for me, paramount. So I think of ourselves, our profession, as a key healthcare provider. Our job is so important. We are the protector, our patient's best protector of their health span. So I want you to put your superhero cape on and really dive into helping heal our patients. So I had to ask myself, why is the body allowing this dysbiosis, this oral mass of undulating spirochetes? What is happening that I'm missing here by telling my patients, you need to brush more and floss more because you're not doing it? You know, but why? You know, prehistoric man did not have tooth decay and gum disease like we do in this modern world, 21st century. He had beautiful straight teeth. He had healthy gums, very little, I mean, he had calculus, but he didn't have aggressive periodontal disease. He had all of his teeth. He didn't have the breakdown, the melting of teeth like we do. And so I had to look at what else is going on. Why is this breaking down? So I'm looking for the root causes of our chronic disease, and it breaks down to three, I've simplified it, three things: airway disturbances, toxic materials, and infection and inflammation. Airway is number one. If we aren't addressing and looking deeper at our patient's airway, then we are doing them a disservice if we're only repairing teeth and scraping teeth. You know, for the longest time, I didn't know what caused those little divots in the teeth. I had no idea. And I just thought, oh, they're clenching and grinding. Well, that is the first sign, that little tiny divot on the mandibular, first molar, little, one of the cusps, that is acid reflux. And that little tiny sign is a great indicator of airway because they are not breathing when they're sleeping. They're going, and they're bringing up acid air, and they're dissolving their enamel. So if you're seeing acid wear facets, like the big ones, like somebody took an ice cream scooper, you've got an airway issue, you have acid reflux. And they're going to tell you, I don't taste anything in the morning. It's like, well, yeah, let's take your pH first thing in the morning, and then we'll see what's really going on. So acid wear facets, indicator, airway. And then long face syndrome, sleeping with their mouth open, snoring, dry mouth first thing in the morning, they have airway issues. This is wrong on so many levels. But that's what we're doing to try and keep our kids from sucking their thumb. But sucking the thumb is actually the smart way that these kids are opening their airway because they want to breathe. So that thumb sucking opens up so they can sleep and they can breathe. And it also stimulates the trigeminal nerve. It releases endorphins. So it makes them feel good. So we've got to get the tongue up there, widen the mouth, get that airway open. And then, you know, chinlessness, long face, airway. And then my favorite, because we're working so hard to heal this, perio and caries. When you have perio and caries, you've got an airway issue as part of the problem. So we've got to look at that. And then clenching, grinding, broken teeth, airway. So all of our patients have a myofunctional disorder, And it's up to us to figure out and fix it before it destroys them and their health. And then toxic materials. I mean, you guys are here because of those toxins, the mercury, the fluoride, and all the bad things that happen in the mouth. You know, when I went to hygiene school, and you probably all learned this too, is once you triturate that mercury, you are good to go. It is locked in the tooth. Except that I looked at those amalgam tattoos, and it's like, that's not locked in the tooth. How'd that get there? And it's like, does it only come out the bottom? I mean, that's a pretty long trip. How does it go from up here all the way down and then up and into the tissue? Psst. But I was told that it was safe, as all of you were. And yet, here is a great photo of mercury bubbling out of an amalgam. That's what that yellow picture is. Those are mercury bubbles. And then, you know, the galvanic reaction, and then fluoride toothpaste. And I used this picture in a talk I did for a dental hygiene school. And I was specifically told, you are not allowed to talk about fluoride. You can't say anything bad about it because they're taking a test and we support it. It's like, all right, because I really want to do this talk. And so I had that picture and I just said there are a lot of toxins in toothpaste, like sodium lauryl sulfate and propylene glycol, and I left it at that. And I just said, if you don't want to swallow it, it shouldn't go in your mouth. So, hopefully they got my message. Doing my best. And if it has a poison sticker on it, it also shouldn't go in your mouth. And here, we're putting it in people's mouths. So, and then, you know, root canals are also toxic. You know, I mean, it's full of bacteria, and we just turn a blind eye to it because we can't feel it. And then our water lines. So if you aren't using ozone in your water bottles, I encourage you to, because ozone kills the bacteria and dissolves biofilm. And that is not my water bottle. My water bottles are clean. That is the water from my good friend Amanda Hill. She was testing the water at an airport, and that was what she got. So it's you know, we practice at such a higher level. So it is encouraging that we already deal with all of these. And then you've all seen, I hope, the smoking tooth video. I tell my patients, go look at that. If there's any question they want to hold on to their mercury fillings, I tell them, go look at it on YouTube and then let's talk. Because this is what your tooth is doing. And then I look at inflammation in the body. What is happening in the body? And as Karen talked about, you know, mold. So many of our patients have mold toxicity. And that, you know, we need to have collaboration for those people. We need to work with our primary care providers and help our patients to have the building blocks to be healthy, because this is only a symptom of a greater systemic breakdown. This is the neon flag. This is the help I need. My body needs help healing because I don't have the building blocks for health. And that includes nutrients. You know, we need those micronutrients, the minerals, the vitamins, the good proteins, the good fats. We've been told fat is the enemy, and in real life, fat is, you know, we need fat. We need good fat. And then we need to look at the bacteria, the fungi, the parasites, the viruses. 99% of the bacteria and the microbiome are healthy and good. So we can't get in there and just annihilate all of them. And then we also need to look at stress and sleep or lack of it. You know, and I always ask my patients, because I'm looking at their airway, I'm looking at these tonsils that look like golf balls. I'm looking at this uvula that looks like a sprung slinky, and I know they aren't sleeping well. And I can see the signs. And if we don't sleep, we can't heal. And sleep, you know, so many people are like, I only need 4 hours. I'm good. No, you're not. You are sleep deprived. You can't heal without sleep. So we've got to help our patients to open their airway to stop the inflammation in the rest of the body. And yesterday, Fran has showed this medical history. It is the best medical history I have ever seen. So we can hook you up with it. Fran has the link to it. We've got to dive deeper. We have to be the healthcare detectives for our patients so that we can figure out how to help them be healthy, not only orally, but systemically. So looking deeper. And then nutrition. That's where the real healing begins. Without gut health, nothing else matters, except for airway. Airway, gut health. Because we can't heal without the building blocks of health. And if you haven't read Dr. Weston Price, I encourage you to get this book and have it on your bookshelf and share it with your patients. This is kind of our dental health Bible. To have it's his adventure throughout the world and what he saw. He went to 17 isolated communities. He analyzed their dental health, their food. He took photos. He counted the amount of caries in these isolated communities. And then he went to neighboring communities that had the standard American diet. And surprise, surprise, the standard American diet people had destroyed microbiomes and destroyed teeth and unhealthy. And look at how beautiful and healthy and straight. We would put orthodontists out of business if we just ate and breathed through our nose. And we put dentists out of business too. And is that a bad thing? Can we find another job? So when we don't eat healthy, and as Karen talked about, leaky gut, gut dysbiosis, you know, and then we talked about it upstairs earlier as well. You know, we aren't absorbing our nutrients, and we are creating an autoimmune reaction because we have dead bacteria and food particles in our system, and that triggers that autoimmune reaction. And so how can we absorb our fat-soluble vitamins if our gut health is compromised? And as I shared yesterday with the group, one of the things that fluoride in our water does is that it destroys the gut lining. So every time we're drinking tap water, we are destroying our gut lining. And that kills the microvilli in our gut. And if you want the research, I've got that. It is from the National Toxicology Report. And so here we're trying to heal teeth with fluoride, and instead we're destroying our gut health and we can't absorb our nutrients then. So every time you eat or drink, you're either feeding disease or you're fighting it. So I take a closer look at everything that I put in my mouth now. And I look at it, you know, because I value my health and I want to feed my family good food. And so is it healthy? Is it poison? Or is it going to feed and support me? So to do my job as a biological hygienist, I want to heal my patients, support my patients, and give them the foundations for health. And so that starts with the microscope. I can't work without one because I've got to know what I'm dealing with. And my mantra is test, teach, treat, repeat until I have a healthy mouth and a healthy microbiome. If you're not testing, you're only guessing. And we aren't guessers. We are healers and healthcare practitioners. You know, I look at this slide, I look at these teeth, and they're clean, they're healthy, except that I touch your gums and they just explode. And why is that? And that's what the microscope starts to tell me. Now, is it the be-all, end-all? I still use salivary diagnostics, but right here, right now, I want to know what's happening, not 3 weeks from now when she's gone and I've had 40 other patients. I want to be able to show the patient what's going on right here, right now, and let's do this to change and to start your healing. Along with the microscope, you can see I've got the microscope there. This poster from Mama Gums tells the patient What is good, what is not good. So in a healthy mouth, we have cocci and we have plaque. We're always going to have plaque. That plaque pellicle is supposed to be there, but I want healthy plaque, not diseased plaque. I want plaque that supports and buffers and remineralizes and sets the stage for a healthy mouth. So in 20 minutes down the road, that microbiome is already starting to regenerate. Is it going to be a healthy microbiome or is it going to be disease? So I want very little movement. I want the cocci, they are stationary, and it's nice quiet. I tell the patients, I'm looking for, is it a lazy Sunday river or is it a mosh pit in New York City on Friday night? And that's what I'm going for. So they get it, they get the picture. Then I look at variety, quantity, and motility. Is it spinning rods like crazy? Does it look like a beehive? Or is it just a few? And then clock arms, captocytophagia, they pivot on one spot. So you can always tell, and they're thinner than the long gliding rods. And then in the high risk category, spirochetes and rods. And then we'll often see white blood cells. White blood cells aren't supposed to be there. The body sends them when there is inflammation and infection. And so if I see a lot of white blood cells, I know that there's a problem. The body has sent our warrior cells into that site. And so we've got to dig deeper as to what's going on. And then the parasites, they're so cool when you see them on the slide. And I'm always so glad they aren't in my mouth. But the amoebas are oozing across the screen, and then the trichomonads look like baby mice running around the slide. And so they're cool. The patient's always disgusted when they see them. All right, so this is a healthy slide. So you can see, it's a lazy Sunday river, right? That's what we want. That's a healthy slide. And that correlates with what I see clinically. And that's what I want. And I want to give that patient their gold star. If they look like this and they don't have decay, they get to go every 6 months. Otherwise, I want to see them every 3 to 4 months. So they have to earn that 6 months from me. And when they get up front and they say, oh, Barbara said 6 months, they're like, yay, it's a party at the front desk. Because they are healthy and they have earned that reprieve from me. And then we have a little bit more activity, but I'll still give them an okay. There's still a lot of cocci. These guys that don't move. And then there are some spinning rods. I'm not going to, this is okay. This is a good slide. And then things get a little wild and crazy. So we've got a lot of clock arms. If you look, you can see the little pivots. And this needs a little housekeeping. And I'm going to give them some different oral hygiene and work with them a little bit more on what they're eating and get them to breathe through their nose, and nasal hygiene. If you aren't talking about nasal hygiene, we've got to get them to use their nose. If they're mouth breathing, they're going to have that dysbiotic biofilm. So you've got to ask your patients, can they sit there with their lips together and breathe through their nose? So in my office, because it's airway focused, I give them a piece of paper and they get to sit there while we do the blood pressure and I look at stuff and get the x-rays ready and see if they drop that paper on the floor, because I want them to be able to use their nose. And then we get wild and crazy here. So we've got white blood cells. These are the big white blood cells. That's a red blood cell. And that poor little red blood cell is getting pummeled by some spirochetes. Red blood cells, white blood cells die after 3 days out of the body and in that plaque microbiome. And when they start dying, they become food for all these pathogens. And the pathogens that are dying also become food for their brethren. So a little necrophilia, I guess, going on in there. But the thing about this slide is that, let me just play it again, is that the lady that I took this sample from was 8 months pregnant. And, you know, I've been to AOSH and I've heard Dr. Yiping Han talk about a patient that she had that died. The baby was 8.5 months in utero, due to be born, and then the mother contracted a cold, and then the baby died, and they found that it was the pathogens from the mother's mouth in the, I think, the lungs of the baby. So the pathogens from the mouth killed that poor unborn baby. And so, you know, again, the bacteria don't just stay in the mouth. They travel everywhere. So if you look for Dr. Yiping Han's report, it's out there. I mean, this is going back probably about 15 years. But, you know, these pathogens caught my attention. It was like, okay, we got to deal with this right here, right now, because I want you to have a healthy baby. And you saw how aggressive those spirochetes were. So, you know, this is my passion, and I am so on top of this here. And when I see spirochetes, I suspect, and I don't know for a fact, but I suspect that there will be Porphyromonas gingivalis. And Porphyromonas gingivalis and Treponema denticola are best buddies. They work together. But I'm not going to see Porphyromonas gingivalis on the microscope as readily as I do spirochetes. And PG is the keystone pathogen. All we need is a little bit of PG. And he is a bad actor. And PG is also found in the brains. So when I see spirochetes in the microscope, that makes me, again, more concerned and more aggressive. And then we have my very favorite slide of all. So there's a lot going on here. Isn't it cool? I love microscopes. All right, so we have two oozing amoebas. And then you've got a whole sea of spirochetes, rods, and spinning rods. And we used to think amoebas were, okay. But the current research says absolutely not, that they are high-risk pathogens. And amoebas and trichomonas don't show up in our salivary diagnostics. But amoebas are like a Trojan horse, and they burrow into the tissue, and they open it up, and then look who's coming right behind them. The sea of spirochete armies here. So these amoebas are not benign. And I had an argument with somebody online about that, and I was like, all right, here's the research. You know, I'm not going to argue with somebody. I'm always going to give them the research. So this slide, you're going to see it all the time from me because I love this slide. And then here's the research. This is fairly recent, 2020, that it invades and destroys the gingival tissue. And it further exacerbates inflammation and tissue destruction. So again, you got to know what you're dealing with. If you're putting your instrument in that pocket, you are inviting more tissue destruction. And then yeast. You know, this is my favorite slide for yeast. You see those bubbles on the end? You know, yeast, candida plus strep mutans makes caries more aggressive and the bacteria more virulent. So either if you're not doing a microscope, do salivary diagnostics and look for yeast when you're dealing with your caries patients. And again, you know, aggressive, and here's the brush pattern. The more organized a slide is, the more aggressive a slide is, the more destructive it is. And so even if the patient has really good oral hygiene, and then I do a slide and it is full of bacteria, Well, I know their immune system's good and they have really good oral hygiene and they're hiding this infection. So they can manage it until they can't. They're doing okay, but we know that this bacteria is going into their system. And we know that down the road, it could be a problem. And take a look at down the throat. If you're not making them gag, you haven't looked far enough. All right? So you got to look at the size of those tonsils. How can this person breathe? How can this person swallow and chew and eat good, healthy food? They probably eat a much softer diet. But guess what I found in the tonsil stones? And this is a slide that's 24 hours old. So there's spirochetes in the tonsil stones. So you've got to look deeper. If they're tonsil stones, we've got to get them gargling and disinfecting and getting those tonsils not so big. Yes?
How did you prepare the slide? Did you just get the stone?
I did. I popped the stone out because it's like cottage cheese. I asked the patient's permission before I did it. Okay? But yeah, no, I kind of eased it out because it's just sitting in there. I mean, sometimes they're encased, but this one was right there and it's like, oh, I want this. A cotton tip applicator. Just kind of squeezed it out. Oh yeah, I'm gross. But I just kind of teased it out and then I took a little bit and I put it on a microscope slide because I was curious, like, what is in there?
So were you able to just push it then?
Well, I didn't take the whole thing. I just took a piece of it and then I put it on a microscope slide. So be curious. I look at stuff and it's like, I wonder if this works. Let's put this on a microscope slide and, a disinfectant. I take some plaque, I'll mix it with some, somebody says, oh, my thing kills everything. Well, I use that instead of saline solution. Let's put it on the slide. Show me. Show me that this works. And so, I'm curious. I will take plaque off the tongue and put it on a microscope slide because there's bacteria in the plaque in the tongue. So if you're not scraping that tongue, then you're leaving, like 75% of the plaque behind. So there's bacteria in the whole mouth. It's not just on the teeth. Isn't that cool, though?
So would you suggest that person get their tonsils out? Or?
Yeah, probably. Because they're an adult. When you look at those, they've had a lot of the teeth restored already with crowns. So they've got airway issues. They've broken teeth. They are not breathing properly. So they need expansion and probably get those tonsils out. You need a sleep study. You need, you got to do a deep dive into this. It's not just a simple, take them out. Right. And, because at this point, they're probably never going to shrink because they've been mouth breathing their whole life. But maybe the dog's sleeping on the bed. Maybe we can shrink them. I don't know.
And I have one more question.
Yeah.
When you said about people with sleep apnea, the bacteria crossing the
blood-brain barrier, yeah.
Is that untreated or with treated?
So her question is, with sleep apnea and the permeability of the blood-brain barrier, is that treated or untreated? That's untreated sleep apnea.
Once they have the CPAP,
I can't speak to that. I wish I knew if it heals up. I don't know. So that is a great question. And now I'm curious and I'm going to find out. So I want you all to be curious as well. And then this is one of my favorites. Yes. Trichomonas tenax is the stinking cutest pathogen on the face of the planet. Are they not cute? But do you want them in your patient's mouth? Do you want them in your patient's bloodstream? But how are you going to test for them unless you have a microscope? And oh yeah, he is. He's like a Hoover vacuum cleaner. And And you got to wait for it here. He's coming. Look in here. He's coming. Look at that flagella. I mean, aren't they cute? And aren't they disgusting? And how do you know unless you have a microscope? So I hope you all run upstairs to the microscopes. And we do have one that Fran has here that could be purchased and sent home with you. So, you want it? Or you have a question? I'm sorry, what?
What did you say they were called again?
Trichomonas tenax. And there are other trichomonads in the body, but this is the oral trichomonad. Yes?
Knowing the different types of bacteria, are there like protocols to get them out of the body, or is it always in the microbiome?
So her question is, are they always there? How do we get them out? We will talk about that. Yes. I want a healthy microbiome. So I want to change these microbes to a healthy microbiome. That's my job. That's what we do. So yes, these are all unhealthy. This is where my patients start. But you saw at the beginning where a patient ended. And that's the reward. I mean, to see it every time they come in be healthier and healthier. So salivary diagnostics do have a place, and there are so many good salivary diagnostic companies. So you just have to decide, do your research. Look at each of the companies. There's Bristle, there's OraVital, there is, we have a local one called Phytolab, there is Oral DNA, which is the granddaddy of them all. And there's so much information that you can get with the salivary diagnostic testing. They range in price from $100 to $500. So I like to start with a simple one, and then if I need more information, I'll dig deeper. So, but I'm looking for the, what you see on here is the threshold levels, these blue lines. So I want to make sure that everything is below those blue lines. And this is a salivary diagnostic from a local company in Seattle called Phytolab, and they give me a score. And this score is 2.87. And sometimes I'll have this score be 500. So 2.87 is good. I want it below 20. But, every company does a little bit different testing. For your salivary diagnostics, there's also, you should be testing your caries patients. Because, again, we don't know if we don't test. Why are they getting caries? Is it because they have a high bacterial load, or is it because they have gut dysbiosis, diabetes, gluten intolerance, eating disorders, something else that's causing their caries? Another test that I use is the caries screen from Carimeter. And this, I'm looking at the bacterial adenosine triphosphate. Adenosine triphosphate in healthy cells versus disease cells, they are 100 times more in caries-producing cells, or in caries-producing bacteria. So the more cariogenic the bacteria, the higher the number. I want the number on the meter to be below 1,500. So 8,795, this patient has a high decay bacterial load. And so I'm going to be preventive, even if they don't have active decay. They get it. We got to lower this number so that they have a low bacterial load. And then Ferris 6, you can download this, test their airway. Real quick, real easy. This is free. And there's the Ferris 6, the Ferris 8, the Ferris 16 or 18. So you can get more elaborate. But this is, you can laminate this, have it chair side, and just boom, can they breathe through their nose? When they put their lips together, is their mentalis strained? What do their tonsils look like? The last tonsils look like number 4 there. They almost occluded the airway. And then look for anchoglossia. Pick up that tongue. Look underneath it. I have had so many adult patients who the orthodontist retracted, straightened, and the orthodontist never lifted up their tongue. We've got to look at the tongue. If the patient can't open their mouth wide and put their tongue on the roof of their mouth, the tip, then they're probably tongue-tied. But that's where you're going to go and get that myofunctional training. And then, is there wear? You know, so many of our patients clench and grind. They clench and grind because that opens the airway. When they clench, that opens their airway, and then they grind, they wake up, they go back to sleep, and they breathe in there. So testing and looking at wear. If their teeth are chipping, airway. And then look at the palate. You know, we take photos in my office, and I always look at the palate. I stick my finger up there, and I'm looking. So, you know, if they test yes to all of those, you got an airway issue. What? Sorry. Okay, next is teach. We gotta educate our patients. We can't just throw a toothbrush at them and say, see you in 6 months. I use a tricolor disclosing solution. And blue is acidic plaque. Pink is new plaque, purple is old plaque over 48 hours. And I disclose every one of my patients. And I hand them a mirror, I hand them a toothbrush, and we do it together. Now, I have 90 minutes a patient so that I can teach, because that's the most important thing I do. Because if I leave somebody like this and just get in there and clean, within 48 hours, that plaque microbiome is going to be right back to where it is, because they don't have the skills, the knowledge, and the right tools to get that plaque off. And they're going to have white spot lesions and breakdown and decay. And if you don't have a tongue sweeper on your instrument tray, I encourage you all to do that. This is called a tongue sweeper. It is metal. It is part of my armamentarium. It goes through the sterilizer, and we sell a ton of them at the front desk, because I am showing every patient what is on their tongue. And I take a plaque sample from their tongue and I'll put it on a microscope slide and show them what's on there. All right, next is treat. How do I detoxify and eliminate and change that microbiome? The thing is, you got to have the tools for the job. We can't fight this war with clubs, sticks, and string. So that's why we have to up our game. We also have to up our game because there are pathogens that are resistant to our scaling. AA, PG, is the keystone pathogen, PT or PI, TF, Parphomonas micro, gram-negative enteric rods, and yeast. And then, I didn't know this, but our pathogens invade the teeth all the way to the pulp. So we can't scale our way out of this either. So if your office is only scaling, or traditional, not you guys, because I know you're doing more than just scaling, but those traditional offices that are scaling the heck out of those root surfaces, they're opening up those tooth tubules, and they're giving the bacteria further license to enter the tooth. And they have found the bacteria of periodontal pathogens all the way into the pulp. So those roots act as a reservoir for the pathogens. How do we detoxify? So here is a microscope slide. And so I took a plaque sample, divided it in two, sealed one with saline solution, and then I moved another, the other half over, and I put a drop of a biobotanical agent on there. And you're going to see the difference. This is the same piece of plaque, just divided in two. So it can be done very easily, because we can bust that biofilm. Look at the difference. Same piece of plaque. But the bacteria live in that plaque microbiome, and so they're dead. They didn't come out. Pretty cool. My next favorite thing is oxygen ozone therapy. Ozone, if you don't have an ozonator, if you don't have ozone water, ozone oil. I encourage you to incorporate ozone. Ozone is, so the microscope's my right hand, ozone's my left hand. Ozone regulates the immune system. It boosts the immune system so it can heal itself. It stimulates the uptake of oxygen. You know, all of our chronic diseases start because of hypoxia, lack of oxygen. It improves the circulation. It makes the red blood cells slippery so that they can go in to those little tiny capillaries and heal. It increases the antioxidant protection. It is a mitochondrial stimulant. We need healthy mitochondria. Without mitochondria, we start to die. And the list of what ozone does just keeps going and going and going. So, the most important thing is that ozone busts the biofilm. It is the only thing that's going to penetrate and get into the biofilm and dissolve it. So I use ozone gas, ozone oil, ozone water. And I've got an ozonator right on my chair side, and then all my water units are ozone. And then I also put ozone oil on my glove, and as I'm hand scaling, I'm disinfecting as well, so that my patient is getting ozone, ozone, ozone. Because I want to clear out that microbiome and reset it, kind of like an Etch-a-Sketch, and give the patient, you know, talk about food, nutrition, airway, and then have a healthy microbiome grow. Ozone will penetrate the tooth. Ozone gas penetrates 3 to 5 millimeters into the tooth structure and into the tissues. So all those dirty tooth tubules, we can disinfect them, and then we can close them off with ozone. And ozone water, you know, I use it, again, in everything. Ozone oil lasts indefinitely. It's not as strong, and it's slower, but I can send the patient home with that and say, here, put this underneath your gum line, brush your teeth with it, put it on a pick stir, put it on a soft pick, work it in, rubber tip it in, disinfect.